Welcome to The Explainers. Today, we're going to break down a really classic scenario. Your patient with cirrhosis is suddenly confused. By the time we're done here, you're going to have a rock-solid framework to manage this situation confidently every single time.
So, picture this. You're on call, and you get that page. It's a situation that can feel pretty overwhelming, right? But don't worry. We're going to build a systematic approach, a mental model, that cuts right through the noise and lets you zero in on what actually matters. Okay, first things first, let's define the problem. Hepatic encephalopathy, or HE for short, isn't just one thing. It's a whole spectrum. And the key words you got to remember are reversible and neuropsychiatric. At its core, it's brain dysfunction that happens because a failing liver can't clear out toxins, like ammonia, from the blood.
And just to give you an idea of how common this is, we're talking about a huge number. A staggering 30 to 45% of all patients with cirrhosis will develop what we call overt, or clinically obvious, hepatic encephalopathy. So yeah, this is not some rare complication. It's a core part of managing advanced liver disease.
So you suspect HE, the patient's history is pointing you in that direction. Your very first move, figure out how severe it is. And this isn't just for funsies. Grading the severity is what's going to tell you everything. Does the patient need the ICU? Can they stay on the floor? How aggressive do you need to be with the workup?
And this table here illustrates that spectrum perfectly. You know, grade 1 can be super subtle. Maybe the family just says he's just not himself. Then by grade 2, they're clearly lethargic and confused. Grade 3 is stupor, where it's really tough to get them to wake up. And grade 4, well, that's a full-blown coma. Recognizing this progression is absolutely vital.
Now, let's talk about your most important physical exam finding, asterixis. You ask the patient to hold their hands out, palms forward, like they're trying to stop traffic. In grades 2 and 3, you'll see this classic jerky, flapping tremor. It's a total hallmark of this kind of metabolic brain problem.
Okay, this brings us to one of the biggest, and I mean biggest, points of confusion for trainees. That knee-jerk reaction is to immediately order a serum ammonia level. But what's its actual role here? Is it really the slam-dunk diagnostic test we sometimes think it is?
And here it is, the crucial takeaway. Hepatic encephalopathy is a clinical diagnosis. Let me say that one more time. It is a clinical diagnosis. It's all about the history and the physical exam in a patient you know has liver disease. Sure, a high ammonia level can support your suspicion, but a normal level does not rule it out. So please, don't let a single lab value steer you away from your clinical judgment.
So, you've diagnosed and graded the HE? Awesome. Now comes what is arguably the most important job of all. You've got to put on your detective hat. See, patients with stable cirrhosis don't just develop HE for no reason. Something almost always tipped them over the edge. Finding that trigger and fixing it is the absolute cornerstone of treatment.
Think of this as your investigative checklist. You need to systematically hunt for these triggers. Is there an infection hiding somewhere, like a UTI or even SBP? Are they dehydrated? Did they have a GI bleed? Are they just really constipated? Or, and this happens, did someone accidentally give them a benzodiazepine or another sedating med? You have to go down this list and rule these things out. All right, you've got the diagnosis, you've graded it, and you're hot on the trail of the trigger. So, what do you do right now at the bedside to start making the patient better? Let's get into the immediate first-line management steps. I want you to think of it as these 3 simple steps happening all at once. Number 1, supportive care. Make sure their airway is protected, especially if they're grade 3 or IV, and prevent them from falling. 2, like we just talked about, find and aggressively fix that precipitating factor. And 3, start the medical therapy to get that ammonia burden down.
Now for a huge, practice-changing clinical pearl. There's this old myth that just won't die that you should restrict protein in these patients. Let me be clear, absolutely do not do this. Patients with cirrhosis are often incredibly malnourished. They've lost a ton of muscle mass. Restricting protein actually makes muscle breakdown worse, which in turn can crank up ammonia production. Your real goal is actually 1.2 to 1.5 grams of protein per kilogram a day.
So, when you start your first-line therapy, lactulose, this is the only target that matters. I'm serious. You are not aiming for a specific dose in milliliters. Your goal is a clinical effect, 2 to 3 soft bowel movements every day. That's how we know it's working to trap and expel ammonia from the gut. You just keep titrating the dose up or down until you hit that sweet spot. Okay, the patient's confusion is starting to clear up. They're getting better. That's fantastic. But hey, our job isn't done yet. One episode of overt HE is a really big deal, and we need to start thinking about how to stop it from happening all over again. So let's talk about secondary prevention and then wrap up with the absolute must-know points. So after their first big episode of HE, that patient should go home on lactulose to prevent it from coming back. But, and this is key, if they have another episode, even though they're taking their lactulose, that's your signal to add a second medication. The standard of care is to add a non-absorbable antibiotic called rifaximin. It's been shown to be way more effective than lactulose by itself at preventing more episodes.
Look, if you're ever exhausted on a long call shift and your brain can only hold on to a few things about hepatic encephalopathy, let it be these 5 points. 1. It's a clinical diagnosis. 2. Always play detective and find the trigger. 3. Do not restrict protein. 4. Titrate lactulose to a goal of 2 to 3 soft stools. And 5. Add rifaximin for recurrence. I promise you, this will guide you well every single time.
And let's end with one last practical thought, something that brings us all back to the real world. Your patient seems to have totally recovered. They're back to their baseline. So, can they drive a car? The thing is, even after the obvious confusion goes away, many of these patients have persistent, subtle cognitive issues, and that has profound implications for their daily life. It's a really crucial counseling point, and it's a powerful reminder that the impact of HE can stick around long after that patient has left the hospital.